Good afternoon. I want to start by thanking Dr. Suleiman, Dr. Hiba, and all the ladies behind organizing this amazing conference, mashallah, and we're thanking you for attending. It's been amazing with your presence. And I'm going to talk about the differences and similarities between Kawasaki disease and MISC. I want to ask, how many of you in the last year have seen Kawasaki disease? Okay, so around maybe 60%. How many of you have seen MISC in the last year? So even a bit more. So this is a good audience, and we're going to see at the end what's your opinion. Do you think it's the same disease or it's a different disease? Let's find out. So we're going to discuss two patients, and we're going to, after that, go into more depth. This is a patient that a lot of my colleagues here from NMC Hospital know. We have taken care of this sick kid together. There's a 7-month-old from an Indian descent who presented with 3 days of fever, rash, non-purulent conjunctivitis, cough, vomiting, and diarrhea. There is no history of COVID or COVID exposure. So only 3 days of fever. He has rash and non-purulent conjunctivitis. So out of the 5 features you're looking for, he has 2. So initial labs were done in the hospital, showed the CRP of 89, significantly elevated. AST and ALT are also mildly elevated. Hemoglobin was low, but not yet meeting the definition of anemia for this age. White cell count was normal, platelet was normal, albumin was 4.25, which is normal, and urine analysis showed some WBCs. So why I gave you these labs in particular, why I only focus on these labs? Because in order to diagnose incomplete Kawasaki, you have to look at all these labs. You have to look at initially the inflammatory markers. And then if you have high inflammatory markers, then you look at the liver function test, you look at the white blood cell, you look at the platelets, you look at the albumin and the urine analysis. So 5 tests that are important for you to diagnose incomplete Kawasaki. Or also the hemoglobin, so 6. Now, the echocardiogram was negative. And function was normal, and there was no effusion. So a lot of you know this diagram. This is the diagram to diagnose incomplete Kawasaki. So the patient did not meet full criteria for Kawasaki disease. We have to know, is this incomplete Kawasaki disease or not? So we assess the inflammatory markers. They are positive. So we go down. We have 6 laboratory workup, if you can see here. These are the 6. And if you have 3 of them, that shows you that you have incomplete Kawasaki, or if you have a positive echo. So the echo was negative, right? So the patient was maybe anemic, just at the borderline, okay? Platelets were normal, albumin was normal, there was elevated ALT and AST, white cell count was less than 15,000, and the urine, there was positive white blood cells. So this patient, if you include the hemoglobin as anemia, he just barely met the criteria for incomplete Kawasaki. Can I have maybe one of those microphones? So we decided to treat this patient, thank you, as incomplete Kawasaki, and we decided to go ahead and treat. So IVIG was given to the patient on day 4 of illness, so we gave it very early. And also low-dose steroids was given because we saw this patient when we had a lot of MISC patients, so we always had MISC in our mind. So we gave part of the treatment for MISC is steroids. And also there is some types of resistant Kawasaki disease that are resistant to IVIG, especially in younger patients, and you add steroids with the IVIG from the beginning if you suspect this patient will be a resistant case. High-dose aspirin was also given. Now, a few days after admission, the patient actually developed more symptoms of Kawasaki disease. He had mucous membrane changes and extremities swelling. Now the patient has 4 out of the 5. So definitely, this is a complete case of Kawasaki disease. So we were very happy that we gave him the IVIG. And also the patient developed induration at the BCG site. And this picture, we actually published it in a magazine for case reports. So now tells you that this is Kawasaki disease. This is a very sensitive sign. So now there are so many that happened, but with the IVIG, the patient was still febrile. So was giving another dose of IVIG. And after that, fever was going down a little bit, but we felt that this patient is actually high risk. So we gave him also steroids. After the IVIG, he was still febrile, was giving pulse steroids. Now, at the time we discussed, should we give him high dose steroids or should we give him infliximab? My opinion was to give infliximab, but the rest of the team, PICU and a rheumatologist, was going with the high-dose steroids. So high-dose steroids was given. And unfortunately, we had a repeat echo, and the patient had the beginning of dilation of the coronaries. So after that, after the high-dose steroids, the patient became afebrile, okay? But the CRP was still elevated. So if you have an elevated CRP, despite the fever is gone, you still have to take this patient like he's still febrile. So you have to keep treatment. So we give infliximab to this patient after the IV steroids. And the CRP went down from 150s to 60, but the next day went up to 70 again. So the inflammation was still ongoing. This is an echocardiogram of the patient. That's there in the middle is the aorta. And the big shadow next to it there is the LCA. The LCA, the left coronary artery, it measured around 16 millimeter, which was almost as big as the aorta. Also, there was significant aneurysm. You can see that ball there on the left. That's an aneurysm of the right coronary artery. So this patient unfortunately developed severe coronary aneurysms despite taking 2 IVIG doses, despite taking high-dose steroids, and despite taking infliximab. At this point, the patient was taking aspirin, was taking also another antiplatelet medication, and also was taking low molecular weight heparin. So we were following the guidelines. When you reach this stage, you have to have the patient on multiple anticoagulations. Unfortunately, despite all this, and the patient now afebrile, he had irritability and ECG. We had some ECG changes, and we had cardiac dysfunction. Then we noticed that he had actually a big thrombus in the LCA. The patient is still surviving, but unfortunately he had some complications. Until now, he is on a lot of cardiac medications. So despite all our effort, despite having all vigilance, there are some patients who you're probably gonna have the complications, especially the younger ones. So once you have a patient who is around close to 6 months, or patients more than 5 years, those patients are usually at higher risk of developing coronary artery aneurysms. Also, something very interesting, studies found that when IVIG is given early in the treatment, like before day 5 of illness, those patients are at actually high risk of developing coronary aneurysms. Anyone knows why? Why those patients who were given the IVIG early developed coronary aneurysms more? Yes? Excellent. So it's a more severe case of Kawasaki to begin with. So usually we rarely think of Kawasaki disease at day 3 of illness, right? Once you see a patient with rash and fever, you think maybe viral illness. Who thinks of Kawasaki at 3 days? It happens, but it's rare. But if you actually diagnose Kawasaki so early, that means this is a very bad case of Kawasaki disease. And those patients are at higher risk of coronary aneurysms. And this is the patient that goes with it. So no one now would argue that this patient was a severe case of complete Kawasaki disease. But we have some blood work that came back. He was positive for COVID, anti-spike antibodies. So was he MISC? Was he Kawasaki? Maybe, we don't know. Second patient, 6-year-old girl with fever for 9 days, conjunctivitis for 1 day, lip cracking, and mild abdominal symptoms a few days ago. Patient was admitted a few days ago and treated as gastroenteritis because she tested positive for rotavirus, but fever continued after discharge. Patient came to us after suspicion of MISC as history revealed after the family told us that the father had COVID 4 weeks ago. CRP was 200. AST and ALT were mildly elevated. Hemoglobin was 11, again mild anemia. White cell count was 4. Platelets were low, 145. Albumin was low. Urine analysis normal. So if you go back again, does this patient meet the criteria? So there was anemia, platelets was low, albumin was 3, so just about 3. Elevated ALT were there. White cell count was actually low, not high, and urine analysis was negative. So again, barely meeting the criteria of Kawasaki disease. And the age does not go, 6 years old. So echo actually showed mild dilation of the coronary arteries, and the ejection fraction was low at 49%. So patient was admitted for IVIG, steroids, and aspirin. Due to hypotension, low dose of inotropes were given. Patient quickly improved and was discharged on weaning dose of steroids and aspirin. On follow-up, there was normalization of the coronary arteries. So what do you think? This is Kawasaki or MISC? This is most likely MESI, right? Because there was decrease in function, the age goes more with MISC, and now we're going to discuss the differences, how you diagnose Kawasaki from MISC. So quick overview of the two diseases. Kawasaki disease incidence higher in siblings and in parents, in the, let's say, offspring or of parents with Kawasaki disease. It's most commonly in Japan and children of Japanese descent, so definitely there is a genetic component. And these are the genes that were on multiple studies confirmed to play a role in Kawasaki disease. The pathogenesis, usually there's inflammation of the medium-sized arteries, especially the coronaries. There are the 3 stages of Kawasaki disease. I'm not going to go over them now, but we all know the symptoms: the rash, the extremity changes, mucous membrane changes, the strawberry tongue, the conjunctivitis. So the most commonly one that happens are the mucous membrane changes. The least one that happens is the lymph node enlargement. It happens on less than 50% of the patients. Now, coming to MISC genetics, there's almost no doubt now that MISC is triggered by COVID. This is, khalas, we are sure of that. But we don't know what's the virus behind Kawasaki, maybe multiple viruses. Patients might have inborn errors of immunity that together with COVID infection trigger MISC. You can, in the same family, have patients who develop MISC and others don't. Surprisingly, MISC is very, very rare in East Asia. Almost no cases, almost, in Korea or Japan. This is very weird. Despite having so many Kawasaki patients, MISC is almost unheard of in Korea and Japan. The incidence of Kawasaki shock syndrome, on the other hand, which is similar to MISC, has the same, let's say, geographical area like MISC. So Kawasaki, the regular Kawasaki, has probably different genetics than Kawasaki shock syndrome, because Kawasaki shock syndrome still happens in the same population like MISC. So now MISC also have some genetic identifications, and those all the genes that have been identified to be associated with MISC. Surprisingly, I went all over them all, and they are not the same genes that are involved with Kawasaki, so different genes. This is the pathogenesis of MISC. Initially, you have the exposure, and after the exposure, you have the activation of the immune system and the cytokine storm, which leads to severe inflammation, leading to the symptoms of a patient. And we all know the symptoms: headache, meningitis signs, GI symptoms are very common, definitely the fever. Myocarditis is more common than Kawasaki. Pulmonary symptoms are also more common. The conjunctivitis, the rash, lymphadenopathy, stomatitis. So there are similarities and there are differences. There is a genetic predisposition in both of them, but the genes are different. In MISC, we know that COVID is the trigger. In Kawasaki, till now, we do not know a single virus that can trigger Kawasaki. Till now, nobody knows. In Kawasaki disease, there is a pro-inflammatory process, but in MISC, there's a cytokine storm, much more inflammation than Kawasaki disease. Now we come to what really interests you more is the clinical presentation. What is the difference? So now coming to clinical differences, Kawasaki disease is more common in East Asian. MISC seems to be more common in Latinos and African ethnicities, but here we saw so many cases in UAE from all ethnicities. Usually in Kawasaki disease, patients tend to be younger, around 2 years. But in MISC, patients tend to be older. The average age of MISC is around 8 years. The skin manifestations are more common in Kawasaki disease, but in MISC, more GI symptoms. There is also hypotension and shock more common in MISC. Coming to laboratory differences, also very important to us. Kawasaki disease has more increased white blood cell with neutrophilia. There is usually no lymphopenia, and there is high platelets in Kawasaki disease. In MISC, usually markedly increased white cell count, but usually there is lymphopenia. So if you see lymphopenia, think more MISC. Usually there is low platelets, not high platelets. Inflammatory markers are much, much higher, almost 2 times to 3 times higher in MISC as compared to Kawasaki disease. But what is also more important is the pro-PNP. I use this a lot. Usually it's 10 times higher in MISC as compared to Kawasaki disease. And coagulopathy is very common in MISC as compared to Kawasaki. Also, what is the difference in the response to treatment? Kawasaki disease resistance is less common. It ranges in around 5%. Use of steroids, interleukin-1, and tumor necrosis factor inhibitors is less common. But in MISC, there is almost 50% resistance to IVIG. That's why from the beginning we use steroids, and we have a lower threshold to use biological drugs like infliximab. So my conclusion, although most researchers say that MISC and Kawasaki disease are 2 different conditions sharing some common pathological etiologies and characteristics, some still suggest that MISC is a new presentation of Kawasaki disease caused by a single virus, which is, in this condition, is COVID, in genetically susceptible individuals. But if we look at it from a genetic standpoint, we know that the genes are completely different, so maybe they are 2 different diseases. There is similarity in the treatment, but MISC tends to be more resistant to conventional treatment, hence the use of biological drugs is more common. Now people are actually trying to study Kawasaki disease because we learned so much about MISC in the last 2 years. You probably heard the talk over the last 1 day talking about people are now learning more about Kawasaki because we just pushed the field so much in the last 2 years during the COVID epidemic. And a lot of people now understand the genetics and the pathogenesis of MISC even better than Kawasaki. So now it's going to be the same focus on Kawasaki disease. And thank you so much. I think Dr. Sharif finished his talk.
Some questions? Does anyone has any question? Can I ask a question until?
Of course.
Okay. When you talked about this patient, I tend to be a little bit more reserve, you know. So when you said anemia at 11.1, when the lower level of normal is 11. So obviously starting the treatment early doesn't mean necessarily a better outcome because the patient still ended up with the coronary artery disease. So would it have been wrong to wait 1 more day until you have more criteria? Mm-hmm. Okay, and then second question, you said when IVIG is used early on in the course, you said maybe because the inflammation is stronger, but can we argue is that starting IVIG early may lead to a worse outcome?
No. So definitely the IVIG is the only medication we know that saves the patients for coronary aneurysms. We know that steroids don't help. High dose aspirin does not reduce the incidence of coronary aneurysms. So the only medication we know that reduces coronary aneurysms is IVIG, nothing else. so far has been proven to reduce aneurysms. Now, if you give the IVIG before 10 days of fever, you reduce the incidence of coronary aneurysms from 25% to 4 to 5%. So significant reduction. So for sure, IVIG does not increase the risk of aneurysms, but it is the severity of the disease, and this is how it was explained. If you diagnose Kawasaki disease early, that means that this is a severe case of Kawasaki disease, and hence there is the worst outcome. Now, in the Japanese literature, they use other criteria to give steroids early on with the IVIG, hoping to reduce the risk of complications and IV resistance. There are multiple criteria. One of them, the most common, is called the Kobayashi, looking mainly at the age and some blood work of the patient. But because these criteria have not been validated in the American literature so far, the American guidelines do not recommend it yet. But in the Japanese population, there have many. The most famous one is the Kobayashi criteria. Now, whether waiting 1 day or not, we were happy that we made the diagnosis early. So the recommendation is, once you're sure of the diagnosis, go ahead and give. And if you are a physician who see a lot of Kawasaki disease, you do develop this gut feeling when you look at the patient. Is this as the Kawasaki patient or not? And alhamdulillah, in the last few years that I have been in the UAE, we have seen many patients with rash, bronch fever, conjunctivitis, but just by looking at the child and looking at the blood work, you develop a gut feeling whether this is a patient of really Kawasaki or not. And we have so many cases that we did not give IVIG, and we were happily correct that the patient was not a Kawasaki disease. There was one patient that we delayed treatment by 1 day, and that patient ended up being a MISC, not a Kawasaki, but just was 1 day more delay and responded very well to the medications, needed inotropes for only 1 day and improved. So, but I don't have any patients that we actually missed, alhamdulillah, so far.
I'm trying to get this from a pediatrician point of view, as we are mostly pediatricians. A cardiologist would have experience with this. You probably are right in getting a gut feeling and developing as a skill for this. But as a pediatrician, we see more common colds and viral infections much more than we see Kawasaki. And that's where we try to follow the guideline. And instead of referring every patient.
Yeah. So, I mean, in this patient in particular, he had high fever for 3 days. He had the conjunctivitis, was very clear, and he had the rash. So the patient was very, very irritable. So because of the severe irritability, the pediatrician admitted him to the hospital, and that's why the blood work was done. And the patient, they looked at it and said, like, maybe this is Kawasaki, and this is the time when I was called to see the patient. So I think if you see many cases of Kawasaki disease, you will know that they are almost always very irritable. And I don't think any of you will see a patient like this who's very irritable in your clinic with high-grade fever, conjunctivitis, and rash, and still send him home, I think. So that's why the suspicion was high, and we were able to make the diagnosis early.
Thank you for the nice presentation. Just from your observation, if we suspect incomplete Kawasaki, and as you mentioned, and it might be true that they are severe more than the complete Kawasaki. So, I mean, away from guidelines, from your experience, will it be, I mean, more effective if we give, if we treat aggressively, if we repeat the IVIG earlier, a second dose earlier? Does it affect the outcome or not? Or if there is any research you read about this, treating aggressively, will it affect the outcome? I have come across similar case while I was a pediatrician in a Lion hospital like 15 years back. And we had a baby who was less than 3 months. And he came exactly like this presentation, 3 days, high-grade fever, 40 and above. And the rash and the conjunctivitis started later, like second day or third day. And initially started like sepsis with IV antibiotics and other supportive care. But eventually we suspected Kawasaki earlier, and we gave, he was treated aggressively, but in spite of that, he developed severe dilatation of the coronary arteries, and actually the family, they refused follow-up. And they refused to come for follow-up, and they refused to follow up with even the cardiologist. We missed that case after that. We don't know what happened to him. But yes, this is my question. Thank you very much.
So I'm not sure if I got the question fully right, but I mean, usually I wait 24 hours. Some people say 36 hours after the IVIG, the first one. And if still there is a recurrence of fever or no reduction in the inflammation. So even if the patient is not febrile anymore, but inflammation in the CRP is going up, give the second dose of IVIG, and some people recommend from the beginning now the second IVIG to be combined with steroids. Now we know that steroids have been shown to reduce the fever faster, but so far we don't have evidence that it reduces the complications of the Kawasaki disease. Now, so the first part of the question that I did not understand where to give the IVIG sooner, I usually wait 24 hours.
Yeah, I mean, just like 24 hours, ideally to give if you suspect like severe disease. Thank you.
Sorry, there's Dr. If you can.
Thank you for your presentation. As regards the first case, I have heard a part of it, and you said that your patient developed thrombosis in the left anterior descending. We have seen cases like that. It's surprising that it is occurring at the same period. The past few months in more than an infant, less than 6 months. Actually, the first one was 2 months, developing thrombosis in an incomplete Kawasaki with fever, with mild signs, not fulfilling the criteria, and then coronary aneurysms occur. And then the patient developed this thrombosis, and we didn't find in the literature whether to give alteplase or not, but then both coronaries were obstructed. It was the left and then the right, and then we give alteplase. Did you use it, alteplase?
Yeah, of course, you have to give it.
Yes, and
So,
the patient improved, and then after the patient improved, we are continuing with the anticoagulants, and surprisingly, the patient redeveloped thrombosis again, and we have to give alteplase once more. And that is why I'm saying these are difficult. We haven't been seeing such strange cases before. And this patient, surprisingly, his serology, he had a positive IgG. COVID IgG, yes.
So
but the
like
clinical picture was that of a Kawasaki and not of a Messi.
So we know that the younger you are, even if you have MISC, the more you look like Kawasaki.
Yes.
And the older you are, if you have MISC, you usually look like a toxic shock syndrome kind of picture.
Yes, but I think it is that one was really a Kawasaki because of the very prolonged fever, weeks, that stays for weeks. I think it was more with really a Kawasaki, a typical.
So also the younger you are, the higher risk of having coronary aneurysms.
Yes.
So you have to have, when you have a large aneurysm like this, you have to be on 3 anticoagulations, aspirin, clopidogrel, and also heparin or warfarin.
Yes, and
so
that's what is strange, that the patient developed thrombosis twice, even on this very strong anticoagulation.
Many reasons, inflammation, the dilation and the stasis, also the high platelets. This patient, when he had the thrombus, his platelets were almost 1 million.
Yes.
And if you looked at the coronary, it was very large, but the os was very small. So it's like a bottleneck. So the flow was very...
That's the same, exactly like the other case. And one of the clues that this is a Kawasaki is this increased number of platelets, because it doesn't occur in the Messi.
You're right.
Thank you.
Thank you.
Thank you.
We will proceed.
Dr. Fathi, maybe another opportunity to ask the question. Okay, thank you, Dr. Anas, and thank you, Dr. Michael, for your presentation, for the award.
Okay, now we will